my talk will have to be in English. I apologize for this. I hope that next year I will be more fluent in Italian. I would like to start my talk by thanking Dr. Andrea Lucci for the kind invitation to come here and discuss with you one of my favorite topics, which is milk and dairy. And whenever we talk about milk and dairy, there are many topics that we could discuss. But we only have 30 minutes. This means that I will have to only focus on the more controversial or ignored aspects of milk and dairy, and the others I will have to skip, of course. So whenever we talk about milk and dairy, it's important to briefly discuss the history of milk and dairy, because we didn't always drink milk from another mammal. And in order to talk about the history of milk and dairy, we need to look at our own evolutionary history. And we know that about 200,000 years ago, in Southeast Africa, the first Homo sapiens appeared. And he is the ancestor of all of us here. And we know that although this ancestor then led to various other Homo sapiens that left Africa and occupied the entire planet, and for most of their time on Earth, they were hunter-gatherers, and so they followed a type, what we could call a Paleolithic diet. We know that there wasn't one Paleolithic diet. There were various Paleolithic diets, because it depended on the ecosystem exploited. It depended on latitude, on the availability of food, of course. Nevertheless, we know that milk from another mammal was not part of the diet of any hunter-gatherer. And how do we know this? Well, you don't need to be a rocket scientist to know this. Have you ever tried to approach a wild animal? Now try to milk it. It's very difficult to do so, right? So this means that the milk from another mammal was not consumed, but the milk from our own mother was, of course, consumed. And indeed, the typical age where breastfeeding would end was about 30 months in most hunter-gatherer societies, which is very different than what happens today in our Western world. And we know that when we talk about milk and dairy, things started to really take shape about 11,000 years ago with the agriculture or Neolithic revolution that occurred in the Middle East. And this was characterized by the domestication of plants, namely cereal grains, but also of animals like sheep, goats, and cattle. And later on, about 8.5 thousand years ago, we see the first dairying evidence coming from what is today Turkey. And a little later, we see the first evidence in Europe coming from Romania, and a little later in the United Kingdom, and also a little later, we see it in the Sahara in Libya. But this is from camel milk and not from sheep, goats, or cow's milk. And this is, of course, something important. If you look at the human generations and you look at the timeline, you see that this is a very recent newcomer, recent addition to the human diet. Because for most of our time on Earth, we were hunter-gatherers and not agriculturists. So this means that for most of our time on Earth, milk was not part of the menu, and not only until about 8,000 to 9,000 years ago. This is for some populations, not for all. And why is this important? Well, first of all, we know that milk, cow's milk, buffalo's milk, goat's milk, sheep's milk, contain roughly the same amount of lactose. Well, sheep's milk contains a little more. And lactose can have some problems. But let's first of all discuss some common myths. And the first common myth is that lactose is a problem for a young baby. Well, it's not, because human milk contains even more lactose than cow's milk or buffalo's milk, etc. So we know that human milk contains a lot of lactose. So unless you have congenital lactase deficiency, you can digest the lactose in milk. So lactase expression is common in young mammals. And you know that lactose is a disaccharide composed of glucose and galactose. So whenever you ingest milk, which contains roughly 11 grams of lactose per serving, this is a glass of milk, this lactose will travel to the small intestine, and in the small intestine, in the enterocytes, in the microvilli, you have lactase and also other disaccharidases. And lactase will break down lactose into its two monosaccharides, allowing us to absorb those monosaccharides and make use of them. So unless you have lactase, you cannot make use of the energy that is available in lactose. And this is exactly what happened after the weaning period. Okay, I'm going to slow down a little. After the weaning period, we know that the normal phenotype is to stop producing lactase. So after the weaning period, you stop producing lactase. This is normal, of course. This is physiology. There is a principle in physiology, which is called efficiency, economic cost. You won't invest resources unless you need them. I hope our governments would learn from physiology. And indeed, this is what happens. So these people, if they continue to drink milk like these first pastoralists, which had the same genes as their hunter-gatherers' grandparents, those people would experience adverse effects. Let's look at those adverse effects. If you cannot digest lactose after the weaning period, but you continue to ingest it, this lactose will go to the colon, and in the colon you have, of course, bacteria, and this bacteria, colonic and also ileal bacteria, will ferment lactose, producing short-chain fatty acids, acetate, propionate, butyrate, which in small amounts, moderate amounts, it's beneficial. Lactose, we could say that it acts as a prebiotic, but in high amounts, it's not so beneficial. And also, the byproducts of that fermentation is hydrogen and carbon dioxide. And some bacteria can reduce carbon dioxide to methane. And all of this could lead to the typical symptoms of lactose intolerance that you see in your clinical practice, like bloating, gas, diarrhea, pain, and in the case of methane, it could lead to constipation. So there are various symptoms, and I'm sure that many of you who are clinicians are very aware of this. So this means that the first pastoralists had to cope with this situation. And we know that there were genetic changes that allowed them, so polymorphisms, that allowed them to continue to produce lactase into their adulthood. So they continue to produce lactase their entire life, and that would allow them to digest lactose. And today, we know that only 65% of adults, well, it's most of us, but it's not 100%, it's 65% of us, do not produce lactase after the weaning period, but about 35% of us continue to do so. So those are mutants, people who had a genetic mutation that allowed them to produce lactase into their adulthood. And when you look at Europe, which is much more relevant for us than a global perspective, we see that in Sweden, where Dr. Staffan Lindenberg comes from, most of the population can digest lactose. But if you go to northern Italy, you see that in northern Italy, only 26% of the population can digest lactose according to this study. And in southern Italy, only 15% of the population can digest lactose. So this means that most of your patients will be people that cannot fully digest lactose, so they could experience symptoms with lactose ingestion. Nevertheless, even if they have hypolactasia, which means that they cannot digest lactose, this doesn't automatically mean that they will have symptoms. We know that there is a tolerance up to 12 grams of lactose. So this is an average. This means that some people will experience symptoms with 18 grams of lactose and others with 6 grams of lactose. Nevertheless, it's something for you to consider. This is a glass of milk. So most people will tolerate a glass of milk without having adverse effects in terms of gastrointestinal symptoms. And we know that fermentation, which is used to do yogurt and kefir, reduces some of the lactose. So about 20 to 30% of the lactose is reduced. And we know indeed from various studies, intervention studies, that yogurt, kefir and other fermented milks are better tolerated than milk. So this is also important for you also to consider. Nevertheless, commercial yogurt is not identical to this type of yogurt because the fermentation of lactose will lead to lactic acid, and that lactic acid gives a sour taste to yogurt, so the food industry adds powdered milk to give it a sweet taste, besides, of course, adding sugar. But powdered milk is added to give it a sweet taste. So, even low-fat yogurt without sugar added has a high amount of lactose per 250 gram serving. And if you look at cottage cheese, it also has a very high amount of lactose. But if you look at your cheese, the Parmesan, it has a very low amount of lactose. Why? Because you don't use the whey fraction where most of the lactose is. So this means that Parmesan will not give rise to symptoms in moderate amounts to most of your patients, or virtually all of them. But there is something that we should consider. Galactose induces cataracts in animal models and also induces atherosclerosis because it has a very glycation potential. So it glycates proteins even more than fructose, which already glycates even more than glucose. So galactose, it has the highest reactive potential of all monosaccharides that we ingest in our diet. This could explain why in animal models it induces cataracts. But in humans, what we know is that there is this pathway to metabolize galactose into glucose 6-phosphate, which then be used for glycogen synthesis or for glycolysis in order to obtain ATP. So in order to achieve glucose 6-phosphate, you need various enzymes. And some people have a deficiency in this enzyme, so they will accumulate galactose, and that galactose will be converted to galactitol, which could lead to cataracts. This is galactosemia type 2. And some people have a deficiency in this enzyme that converts galactose 1-phosphate into glucose 1-phosphate. And why is this important? Well, because galactose 1-phosphate is even worse than galactitol. And it induces not only cataracts, but severe neurological problems and also death. Fortunately, most people don't have this deficiency, or at least they are not homozygous for this mutation. But they could be heterozygous for some of these mutations, and this could lead to some problems if they ingest a high amount of lactose. So this means this: if you can digest lactose and you have a genetic mutation, you can end up with severe problems. If you cannot digest lactose, even if you ingest milk, you'll have adverse gastrointestinal problems, but you won't have this, or at least to the same extent, because most of that galactose simply won't get absorbed. And indeed, we know that people who have the genotype, this mutation that leads to the accumulation of galactose 1-phosphate, and at the same time have lactase persistence, so they can digest lactose, they have more cataracts than other people. So this is interesting. This means that although you can digest lactose and you could say, well, I'm adapted to milk, that doesn't mean necessarily that you won't experience adverse effects when you ingest milk. Just a reminder, we normally talk about cow's milk, we forget all the other types of milk, but indeed those types of milk are ingested throughout the world. But in Europe, in the United States, most of the milk is cow's milk, and this is why most of the studies that I will show now have been conducted with cow's milk. So I cannot tell you right away that this will be the same with goat's milk or sheep's milk. So let's look at the hormonal effects of milk. And the first hormonal effect is effect upon, it depends on his effect upon glycemia. Well, at least that's what people say. We have a low glycemic index when we look at milk. Nevertheless, its insulin response, it's 5 times higher than would be expected from its glucose response. And it's even higher than glucose. And this has been shown for whole milk, fermented milk, for full-fat yogurt, for milk added to a low glycemic index meal, so it has the same insulin response as white bread. And it has been shown for skim milk and whole milk. There isn't a statistical significant difference between skim milk and whole milk in terms of the insulin response. And we know that babies who are breastfed with a cow's milk-based formula, babies who are breastfed have lower postprandial insulin levels than babies who are fed a cow's milk-based formula. And the question is, well, is this good? Is this bad? So the first thing is to look at intervention studies. We know from intervention studies that consumption of milk could induce reactive hypoglycemia in some people, not all. So there is some inter-individual variation. And we also know that when you ingest glucose, of course, you increase your insulin secretion, it binds the insulin receptor, it activates a signaling pathway that will lead in muscular cells and in adipocytes to the translocation of glucose transporters called GLUT4 to the cell membrane, allowing glucose to enter the cell. But when you have hyperinsulinemia, so high concentrations of insulin, which could theoretically happen if you ingest a high amount of milk throughout your life various times a day, you may end up having insulin resistance. This is a negative feedback mechanism that everyone knows. It occurs in most hormones. So you increase the concentration, you decrease normally the sensitivity of the receptor towards that hormone. And if you have insulin resistance, your pancreas will secrete more insulin. This could lead to hyperinsulinemia. So the question is, does milk do this or not? Well, there is this study done in Denmark by Professor Camilla Hoppe. She gave 24 8-year-old boys who followed the same diet during 2 weeks with a washout period. So it was a crossover study. She added to their baseline diet 50 grams of protein in the form of milk, 1.5 liters, or in the form of meat, 250 grams of meat. And she saw an increase in fasting insulin after the 7-day period, fasting insulin, it's not postprandial, of 105%. This is too much. And in the meat group, she didn't see that increase. And also, the OMA insulin resistance index, which is an indirect marker to assess insulin resistance, increased 75%. And in the meat group, it didn't increase. So what we need is to replicate this study in adults before we start recommending a higher amount of milk to our patients, or simply saying milk is good, it's associated with the reduced risk of type 2 diabetes and the metabolic syndrome. Those are observational studies. You need intervention studies in order for you to establish cause and effect. So in my view, you should be careful about this. Also, we know that insulin not only has metabolic actions, it increases cellular proliferation, cellular differentiation, and it inhibits apoptosis. So this, of course, has some concerns regarding cancer. And indeed, women who were diagnosed with breast cancer, but who had a higher insulin receptor expression, they had the lower survival rate. So this is something that, of course, concerns me. So I'm all about safety. So I would never recommend a higher amount of milk without having more studies establishing its safety. Also, we know that milk increases IGF-1 in children 20 to 30% more than any other food, in adults 10 to 20%, and we know that it is milk and not meat that increases IGF-1, so never put in the same bag, because it's animal protein, milk and meat. It's completely different. So when you cite studies with milk and you say that it's meat, you're making a mistake. Also, we know that IGF-1 increases cellular proliferation, differentiation, and inhibits apoptosis to a larger extent than insulin. So IGF-1 could be a problem or could be beneficial if you're a bodybuilder. It depends on your goal, of course. But my concern is cancer. We know that enhanced IGF-1 receptor signaling is increased, and it contributes to every stage of cancer progression. So this, of course, is a concern for me. And we know that the IGF-1 receptor is being approached in oncology. There are drugs that inhibit this receptor, and this receptor has been called an oncogene. So this is a hot topic in oncology. It's not just a wild dream I had last night before I came here. And we know that people who have higher higher IGF-1 levels have a higher risk of breast cancer and prostate cancer. And we know also that milk increases adult height, linear growth, more than any other food. But we also know that people who are taller have a higher risk for most cancer types. So being taller is not necessarily better than being smaller, as some people would say, I know. And also we know that milk could lead to early puberty. And why is that? Because milk contains estrogens. These are all the estrogens that you can find in milk. And indeed, this study has been published in 2009. It has looked at estrogens in various types of milk. And you see that skim milk even has a higher concentration of estrogens than whole milk. How can this be? Estrogen is a lipophilic hormone, right? Yes, but if you have conjugated estrogens, which is estrogens where you add to that a sulfate, for instance, a salt, those estrogens are now hydrosoluble. And you can see them in skim milk. So most of the estrogens in skim milk are conjugated estrogens. Also, we know that throughout the pregnancy of the cow, the estrogen concentrations in the milk increases. It increases a lot. Look at estrone. The concentration in the first trimester of pregnancy of estrone, and now the concentration in the third trimester of pregnancy. And the problem is, my friends, is that when you ingest milk, when you buy milk in the supermarket, you don't know if it's milk from a cow that it's non-pregnant in the first, the second, or the beginning of the third trimester. You simply don't know. And this, of course, concerns me. Why? Well, first of all, because the estrogen that you have in milk, one of the estrogens, is this one, estrone sulfate, that greatly increases throughout pregnancy. And why I'm concerned about this? Because estrone sulfate is the primary form of estrogens that you have in Premarin and other orally hormonal replacement therapies, which are taken orally. So this means that estrone sulfate is bioavailable orally. And this it concerns me, and indeed in animals, sorry, I will come back to this right now. I just want to show you that in animals, commercial milk is uterotrophic. So this means that milk has hormonal effects. And when you look at the estrogen metabolites in milk, you see that they have more or less, the concentration is similar, although it's lower, but it's almost similar to the concentration you have in adult serum. So the problem is chronic exposure. If you're thinking about 50, 60 years of exposure to these estrogens, it's not the same as exposing for 5 years as you do, or 10 years as you do with hormone replacement therapy. So I don't know what happens throughout your entire life, and I don't want to be part of that experience. Also, most of the estrogens that you see in milk are highly reactive catechol estrogens that are involved in various types of cancer, breast cancer, and also endometrium cancer, for instance, and ovarian cancer. Also, we know that when you induce a mammary tumor in female rats with a carcinogen, DMBA, if you give milk to those rats, you will increase tumor growth. And this, of course, has to do with the hormonal effects of milk. Also, in adults, if you give them milk, you see that the estrone in plasma increases, increases significantly, and testosterone decreases significantly. And if you look at organic milk, it has a higher estrogen concentration than even normal milk. But if you look at goat's milk, it has the lowest estrogen concentration. Also in milk, you see that there are dihydrotestosterone precursors. And dihydrotestosterone, as you know, is implicated in benign prostate hyperplasia, also in alopecia androgenetica, the one that I have, but let's not discuss this right now or I'll get depressed. And also it's also involved in acne. And indeed there are various studies associating milk intake with acne. So my friends, I think milk has various hormonal effects. Let's look at some of the evidence regarding prostate cancer. You see that this meta-analysis shows a high risk, these two, and regarding breast cancer, well, this meta-analysis doesn't show that it increases its risk, but nevertheless, women who were diagnosed with breast cancer, who drank more high-fat milk, had higher mortality in this recent study. Also, this recent study shows that people who eat more dairy products have a higher risk of hepatic cancer. And in terms of ovarian cancer, there is also an elevation in the risk, although it's a modest one. Nevertheless, in colorectal cancer, it appears to decrease the risk, and it has to do with calcium. Nevertheless, people who were diagnosed with colorectal cancer, if they had a high intake of dairy and dietary calcium, that doesn't decrease its mortality. There are other types of cancer associated with milk, although these are all observational studies, and this is a recent one that I'm almost finishing. And this one, people who were lactose intolerant, so they would avoid milk and dairy, had a lower risk of lung, breast, and ovarian cancer. Of course, this is only observational evidence, so we have much more questions than answers. And the big question that everyone asks me, well, should I recommend or shouldn't I recommend milk or a higher milk intake? I don't know, because we simply don't have enough evidence. But we have enough evidence to test it, and I don't think there is any risk in trying a dairy, milk-free diet in our patients. The big question is, where do I get my calcium? Well, this is easy. If you look at kale, for instance, you see that 100 grams of kale has the same amount of calcium that you get in more or less 1 glass of milk, but the absorption rate is even higher than the absorption rate of calcium from milk. Why? Because kale and all the brassica family doesn't contain oxalic acid like spinach do. Okay, so kale is a very good source of calcium, but you have seeds, almonds, some algae that also contain calcium. So there is more in the world than dairy in terms of calcium. So the take-home messages are, first of all, the normal thing is not to digest lactose. This is the normal thing. So digestion of lactose is not the normal thing. We know that fermented milk is a better option for those people, or those types of cheeses, the aged cheeses like Parmesan. And we also know that people with lactase persistence, so they can digest lactose, may experience adverse effects when they drink a lot of milk, as I showed you. We also know that a high milk diet may increase insulin resistance, but we need better studies in order to know if it's true or not. And we also need studies with various types of dairy foods, not only milk. We also know that milk increases IGF-1. We know that it has estrogen metabolites, dihydrotestosterone precursors. All of these can influence cancer risk. But we need trials where you give patients a milk-free diet and other patients a diet that contains milk. And this is something that an ethical committee could approve, because milk is considered a very healthy food. Also, we know that goat's milk has much less estrogens, and we know that fermentation could reduce the estrogen concentrations in milk. So, from my view, goat's yogurt may be the less problematic of all dairy foods. And to finish, I want to tell you that dairy is not the only source of calcium in the world. So there is more to calcium than just milk and dairy. Grazie mille.